Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Julia Adam, 36 years old lady complaining of headache, visual disturbances, and pain in both hands for 8 months. Please take history, examine the patient, and address her concerns. Ready, Dr. Omar?
Yes.
Here you go.
Hi, hello. My name is Omar. I'm one of the doctors here today. Are you Miss Adam?
Yes,
Yeah. Miss Adam, um, I do understand that you have been referred to us for problems regarding headache and some visual disturbance that's been going on for a while. Is that correct?
yes, doctor.
Yeah. So can you please tell me more about your symptoms?
Yes, doctor. This is headache and hand pain. Uh,
Headache
now
and? I didn't hear. I'm sorry. Headache and?
hands pain.
Hands pain. Okay.
Yes. This is
And
it started gradually, and how over like 8 to 9 months.
8 to 9 months.
Yes.
Um,
Also, my vision also has also vision disturbance.
okay. So what do you mean by disturbance?
I mean, I cannot see my side
Do you
when I'm
bump in your
for
sides and the objects on your side
yes,
often?
when I'm seeing forward, I cannot see by side.
Okay. Okay.
Yes,
And these problem has started 8 months. All of them started 8 months ago.
yes. Start by
Oh,
one, and
one by one.
it start like little, then increasing.
Increasing. Okay.
Yes,
So now you can't see the objects on your side. Do you drive by any chance, Mr. Adam?
yes. Sometimes,
Okay. And have you been finding any difficulty with driving?
yes, doctor.
Okay. Well, for now, I do advise you to hold on driving. We will discuss this in a bit. Now, do you believe you are able to do so? Just to hold driving for now.
Yes, okay, doctor. Sure,
Okay,
thank you.
thank you. So now for the headache. The headache, is it where it is exactly? Is it on any side or is it
I feel all over my
all?
head.
Does it improve by any mean? Have you tried any medication, anything for it?
No, I didn't. Sometimes paracetamol, little relief.
Did it improve with when you take certain positions?
I didn't notice, doctor.
You didn't notice that. Okay. And have you noted, is the headache there all the time or it comes and goes
Uh, doctor, it is continuously
continuously?
with a little relief. Yes.
Hmm. And uh, for the pain in your hands, where the pain exactly?
Now also it is for 8 months, but before is little, now is too much.
Okay. But where is it exactly in your hand?
I feel it mainly in my palm and also in my uh,
In your
palm.
wrist or in your fingers, or is it diffuse
Both
pain? You
doctor,
hmm?
both doctor, both in my
Both.
finger, my wrist, but mainly in my palm more.
Any other joint
Palm,
pains?
mainly here, but otherwise little knee pain.
Knee pain. What about your back?
Is okay, doctor. I didn't feel.
Okay. And any other symptoms that you've noted?
I feel sometimes tired.
Tired. Okay.
Yes, yes.
Any change in your bowel habits?
No, doctor, I didn't notice.
Any change in your frequency that you're going? to the toilet for urination?
No, no,
No. Thirst sensation?
no, it's okay.
Any skin rash?
No, no,
Loss of the hair and or problems with the hair, eyebrows?
no, doctor.
Okay. Have you noted any those questions will be about your private life. Are you married? Or
Yes, doctor.
do you have partners? So how's your intimate relation? Do you have any difficulties?
No, doctor. Only my husband noticed that. Um, my face now is not like before. Is
Okay.
like little bit increase.
Okay.
Um, Also even my wedding ring
Uh,
is also become tight.
okay. So you have changes in your facies and in your hands getting a little bit bigger. Any change in your feet?
Yes, doctor. Also I noticed it's not like before.
Any difficulty
Now,
breathing,
no,
snoring? Have
no,
anyone noted that you make noises when you sleep?
no, no, doctor.
No. Shortness of breath,
No.
heart racing?
Yes, doctor. Sometimes
Okay.
I feel my heart racing.
Um, any sweating?
No more.
No more. So there was some sweating at some point.
Yes, doctor. Little.
Any weather preference?
No, no, doctor.
Sorry again. Is your period is regular?
Yes, doctor. I didn't
Okay.
notice change about my period.
Okay. And have you noted any lumps and bumps? Any um, change in your appetite?
No, doctor.
Okay. Do you have any medical problem in the background?
No, doctor. Before I have no problem, but these days,
Mhm.
um, my blood sugar is starting to become high.
Okay. Okay. How high is it?
Uh,
Not,
uh,
I'm not talking about exact number, but is it continuous, consistently high?
it is increasing.
Yeah. Okay. Okay.
I check it 2, 3 times. Every time I find it more.
Is it by doctors or by yourself? Have you seen
My
any
doctor,
doctor for that? Yeah. Okay.
yes, I
Huh.
visit only
Doc
my
GP.
local
Okay.
clinic. Yes.
And does he started you on any medication for that?
Uh, no, doctor. Still, I refuse to start any medication because I didn't have it before,
Okay.
and still I have no idea what's the problem.
Okay. Um, are you taking any other, do you have any other health issues?
No, before no,
Medications? Are you taking any medications?
no, no, no,
Over the counter, unprescribed,
no. Sometimes only paracetamol for pain.
only paracetamol.
Yes.
And do you have any allergies?
What?
Any allergies?
No,
Family history of any medical problem?
no.
What do you do for a living?
I'm teacher.
Okay. And is that impacted your job by any mean?
Yes,
The
doctor.
current
Now,
symptoms, yeah.
yes, yes, doctor. Yes,
Okay.
because now my vision is not like before. I'm not
hmm
feeling okay.
Do you smoke?
No.
Okay. What about drinking?
What?
What about
Drinking? No, no,
drinking? Yeah.
nothing,
No. Okay.
nothing.
Um, is that all right if we started examining you, if you don't mind?
Okay, doctor. Sure.
So, first of all, I would like to see your hands and your feet. Um, and also to take a look to examine your face. Then I'll do general physical examination, measuring the pulse, um, going for the GVP, and then is there any abnormalities up till now?
No, doctor. Only my hand is little bit swallow.
Okay, I'll examine you um nerves in your head. I'll examine your eyes basically. I'll ask you to cover one eye if you don't mind. I'll cover the other, and I will test the periphery of the vision, and then switch my hands to examine the other eye. Um, is that consistent with peripheral vision loss?
Yes, doctor. I cannot see.
Is it
I
peripheral?
cannot. Hello.
Is it bitimbral hemanopia?
Yes.
Okay. Okay. Thank you. And then I'll listen for the heart. Any abnormal murmur,
No murmur. Little tachycardia.
a little bit tachycardic regular pulse.
Yes, doctor.
I'll palpate for the kidney, for the liver. I'll examine the abdomen. So I'll start by superficial palpation and then deep palpation for the organs, any organomegaly.
No, doctor.
I'll take a look on the lower limbs for peripheral edema and listen to the back for any abnormality and check for sacral
Normal.
edema also. Normal.
Back
Any
normal.
apparent
Little bit lower limb edema.
little bit lower limb edema? Is there any skin rash, visible skin rash?
Uh, uh, no, doctor.
No. I'll finish my examination by examining the lymph nodes in the neck, palpate the thyroid, and the lymph nodes under his arms.
Okay, doctor. No lymph node enlargement.
No lymph node enlargement, thyroid.
Normal.
Okay. Well, Miss Adams, thanks for letting me examining you. Um, I do understand from the conversation we had that you are concerned about the
Yes, doctor.
medication that the doctors wanted to start for your high blood sugar, and you wanted to understand what's going on with you.
Yes, doctor.
Is that your main concern?
No, no. Also, doctor, I also my concern. What I have, doctor? Why my body start to increasing like this? Why
Well,
everything is starting to become because before I'm not feeling okay, and also my vision and also headache. What happened for me?
from what you've told me and what I noted, um, that your features, what you are trying to, what you are experiencing is consistent with one of the conditions we know is called acromegaly. Have you heard about it?
What is this, doctor?
2 minutes left.
It's basically the one of the glands that secretes hormone. It's within the brain itself. It sits over the nerve pathways in the brain. When it gets enlarged, it will press on the nerve, so it will give you visual symptoms and then give you a little bit of headache. But it secrete excess hormone, growth hormone, basically, which would tell the body to grow in size. So this is why your hand is getting bigger, why your leg is getting bigger. Are you following me, Miss Adam?
Okay, yes, doctor. Yes, doctor.
Okay.
Okay.
So usually this
Is
it
it
would
serious,
affect
doctor?
also well, this is a very good question. It is something that we do see often. It's not very uncommon, so it has some sort of treatment. But we need to do some tests for that. So till we have the test, the imaging and the blood test, we can answer this question properly.
Okay, doctor. do you need to admit me or I
For the sake of organizing those blood tests and you can be admitted for a brief 1 day to arrange everything, 1 or 2 days. Is that suitable with you?
okay, doctor. Thank you.
Uh, One more thing, it's that your blood sugar will be is affected because of that. So this is why the doctor wanted to start you on medication. Are you willing to take that medication
Yes, doctor.
if needed till we get controlled? And of course, you will stop driving.
Yes, doctor. Because now I am
Yeah.
afraid. I feeling everything is not okay, so I can't take any medication.
Okay, time's up. Examiner question, Dr. Salma, please.
Present your case.
So today I have examined Miss Julia Adam, who presented with headache, visual disturbance, and she's also experiencing some joint pain. She described also a change in her face, in her facial appearance, in the hand, and in the leg, which was noticed by her husband. Other than that, on my examination, which has confirmed those finding in terms of tightening of the wedding ring and her heart examination were normal, no organomegaly on abdominal examination. There was slight lower limb edema, which might be suggestive of um, uh, uh, proper possible heart failure, but this needs an echo for confirming the ejection fraction of hers. She also noted that her blood sugars are erratic, so a little bit on the higher side. She was concerned about not to take the medication that the GP wanted to prescribe for her, and she was concerned mainly about why she's having those symptoms, for which I'm suspecting that she might be having acromegaly.
Okay, doctor. What is your differential diagnosis?
My main diagnosis would be acromegaly. The second diagnosis would be it would be secondary to the pituitary uh, tumor, could be prolactinoma, but it's less likely given that her period is regular and no changes in her intimal relationship. Um, it could be other than that, I can't think of anything other than those two things.
Okay, okay. Then, doctor, can you mention for me what investigation you will do for this patient?
So for this patient, we would like to have insulin growth factor 1 and then to confirm that by oral glucose tolerance test. This is the two specific investigation. For the investigating here, I usually start from the bedside, taking lying and standing blood pressure, doing capillary blood glucose, urinary depth, chest X-ray, and ECG, and then the routine bloods, full blood count, liver function, kidney function, and bone profile. Going to the specific investigations that I mentioned, also brain imaging, particularly MRI, which is better to detect the soft tissue, to assess for soft tissue enlargement within the brain matter. This is how I will investigate this lady. Also, to send the full hormonal panel, including full pituitary hormonal panel, FSH, LH, and TSH, as well as prolactin, of course.
Okay, doctor, how will manage this patient?
This patient needs to be managed through a multidisciplinary approach. First of all, to involve an endocrinologist to acknowledge and confirm the diagnosis, and then to start managing an input with starting her on medications, usually to shrink in the pituitary size before transsphenoidal surgery, which will need uh, either neurosurgical referral, uh, and then physiotherapist because the patient is having some pain in her hand, which it usually could be carpal tunnel as it's associated with uh, uh, acromegaly. She would need occupational therapist to assess her needs at work and at home to see if there is any adjustment that it should be made. Also,
Okay,
oh, I'm sorry. Yeah.
okay, tell me,
Is
any
it time?
medication can be used? Any
Uh,
medication can be used before surgery?
for the particular medications in that can be used in acromegaly, it would be bromocriptine, cabergoline, and also if I remember, this would have uh,
Somatostatin analog?
somatostatin analog. It will shrunk the tumor size before the operation, before transphainodal surgery.
Yes, exactly.
Whilst the growth hormone receptor antagonist wouldn't do that. It would block the preferred receptors only. It would be octreotide, lanreotide,
Yes,
the
octreotide,
somatostatin
this is
analog.
somatostatin. Yes,
Yeah, somatostatin analog.
yes. Uh, Time finish, Dr. Basil?
I think
Let's.
Yeah,
so.
yeah, 6 minutes now.
Okay,
Thank you,
thank you,
Dr.
Doctor.
Salma. Yes, good questions and a good topic. Now your turn to comment, then I will comment.
I think very good, very targeted history. Ask me specifically about acromegaly. Um, you didn't mention that. Is there any blood in stool to exclude any colorectal cancer as a big association with acromegaly?
Mhm.
Yes, this is point is
Yeah,
not
yeah.
mentioned. Yes. Uh, Otherwise, history is good and targeted history.
Okay, so you are talking about clinical communication as a skill. We want to
Yes.
judge on the skill. Okay.
You can see it,
Yes.
Dr. Selma, on the comments. Dr. Bassem has
Yes. So
added.
physical. It started by physical examination. Did he do the proper examination?
Examination. I think didn't do abdominal examination or do it.
Yes, and asked for organomegaly.
Yeah,
Okay. Okay.
but he
And
missed the
also
hand.
something good that do visual, and you need to also to examine for carpal tunnel syndrome.
But
Yes, I
exactly.
missed the
This.
hand. Yeah.
Yes.
Yeah, the
Yes.
hand as
And
size and
I tell
carpal
you that
tunnel.
I have pain in my hand, swelling in my hand, pain. So this is
I
going
didn't do
with
the specific test for the carpal tunnel. Yes, it's
yes, you
true.
need to examine for carpal tunnel syndrome. Yes.
What is the test for carpal tunnel?
Fallon and tunnel test.
Tunnel.
Yeah. Okay, so this is as a physical examination. You will give him. What do you think? By the way, he
Mm,
didn't also examine the facial muscle, or sorry, facial expression or facial features, right?
yes. Yes, didn't mention
The prognathism,
examinations.
the tongue size,
Yes.
the
Yes.
frontal posing, all of them. I think he missed. So also it's target examination for the acromegaly. So it can minus him
Okay.
in both physical examination and in the identify the finding, because he should do those. Not only that, the skin tag, the sweating, right, and the hand size, compared hand to his hand, and also the feet size. He can also do compare. As you mentioned, the abdominal examination is very important. Digital rectal to rule out any blood in the stool. So all of them can be helped to say this is acromegaly with the complication. Hypertension as well, one of the vital. He should ask glucometer beside
Yes.
the glucometer.
I asked,
Okay,
not in the examination, in the
yeah,
investigation.
in the investigation, but in the examination you have to to offer the vital signs, including the blood sugar. Okay, and the dipstick. urine dipstick, and the glucometer. You can also check for glucometer finger prick mark. All of them are helpful to say this is a acromegaly case. Plus, of course, by tempo hemorrhage, which is good you did, but I think you miss also the facial examination or prognathism tongue and the neck itself, the even the acanthus nigricans, proximal myopathy, all of them can be present. Okay, then so both of them will be borderline. Now the clinical communication. You said it's target history, right? So you can say it's satisfactory, right?
Yes.
Yeah. But I
Also in
want
differential diagnosis, I
no, no.
think,
Let's say comment on scale by scale. I won't
okay.
say for the history or systemic review, the abdominal, the GI or the abdomen. It's very important to ask about the bowel motion.
I asked about the bowel motion.
You asked?
Yes.
Okay. If you have asked, it's important. Why the
I
importance
didn't
of?
ask about blood and stool, but I asked about the bowel motion
Yeah.
in general.
Okay. So what are the importance of why
It's
I'm
the
saying
is the connection between the cancer colon and the
perfect? So
uh,
whenever you have the constipation, and it's common to have constipation, by the way.
yeah.
Not only that, for the abdominal pain, tummy pain, it's important to ask, what do you think? Acid brush, what do you think?
In this case or in general?
In this case, as a differential, do you think even you give two differential and one
Mhm.
important differential you have to give in any acromegaly patient, in young female or young patient, not only female, with family history? What do you think the missing the differential? And
Mm,
it's one of the GI symptoms, abdominal pain, acid brush.
the men one.
Perfect. Yes, it's one of the most
Give a
important
picture.
differential. Yeah. So min one here is a fitting differential you have to mention, and you have to rule out by asking about polyuria, polydipsia.
I
However,
asked
it can
for that.
be yes, I know it
Mm.
could be as parathyroid adenoma, not as diabetes.
Yes.
Okay, so it's one of the differential you have to mention, and you have to roll it or to roll them out. Min one for gastrinoma or any uh, breast pancreatic cancer. Okay, so you have
Yes.
now the pituitary. If you have parathyroid, it will be uh, one of the component of min1 as a
Mhm.
differential. Okay, so let's
Mhm.
say clinical communication, okay, to mention as satisfactory, but differential you will be borderline, right, Dr. Salma, because he gave you two only. You want to
Yes.
say something else?
No.
So
Yes.
the
For more differential, you mean for
perfect,
more
yeah.
differential, uh, Cushing can be differential.
Cushing as Cushing disease, right? Not syndrome.
Yes.
Okay, from the
Yes.
brain, pituitary itself. Any pituitary adenoma,
Uh,
you can give it as a differential. Pituitary adenoma, non-functioning pituitary adenoma,
yes.
or
Uh,
the acromegaly or Cushing. Okay,
yes. And also insulin resistant can cause feature like acromegaly.
what is it? Sorry,
Mm.
insulin
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 resistance.
resistance.
resistant. Yes, but as in insulin resistant growth hormone and insulin like growth factor 1 will be normal.
Okay, yeah.
Yes.
Anyway, pituitary adenoma for acromegaly or any other or non-functioning adenoma or min1 are differential in this case, right? Let's go to
Yes.
the next skill will be clinical judgment. Did he do all the investigation, the decision for admission,
Yes.
the management plan? Yeah, I agree also.
Yes.
It was good. He mentioned the investigation of choice, target one, which is insulin like growth factor one, and the oral glucose tolerance test as a confirmatory test. Apart from that, it's called pituitary adenoma. Sorry, pituitary MRI pituitary, Doctor Omar. No need to say MRI for soft tissue. It's MRI pituitary target imaging to the
Mhm.
pituitary itself. Okay.
Okay.
Yeah. The surgery you mentioned it well, transsphenoidal
Mhm.
hypophysiectomy, but is it curable? She asked you, doctor, is it curable?
No,
What
she
this?
asked, is it dangerous? Is
Ah,
it
okay. Is it dangerous?
she
Okay.
didn't ask about curability. So I told her to my answer was we need to investigate first before answering this question because we need to know what extent, how large is the pituitary.
Perfect.
Yeah.
So the danger here. either related to the local or to the invasion locally, or even the complication associated. And the good thing here in the history as a clinical communication, you ask about the all complication of weight gain or the OSA, obstructive sleep apnea,
Mhm.
osteoarthritis, carpal tunnel syndrome. However, you didn't examine the knees. And also, this is one important examination you have to do, the knee itself, to rule out osteoarthritis. So you can find crepitus, which
Mhm.
also you miss, right? But it's good that you remember it while taking the history. This is regarding, so it's a clinical judgment satisfactory. The concern, did he answer the concern well, Dr. Salma?
Yes, Dr. Basim. Yes, it's okay.
Okay, so satisfactory for the
I didn't
concern?
ask about it curable or no. I didn't ask.
Yeah,
I asked
yeah,
only
I
do
added
you.
from myself. That's okay. The last thing, the welfare, he covered the driving point on spot. Whenever he asked, he addressed it, which is good. Some doctors will raise this issue, but he will forget it later on. But the good thing, when he asks you, do you drive? And he said to you, please hold on your driving. So it's a good thing regarding the welfare point, the occupation, the but also one of the very important history here, the female history. You ask about only the period, and always we are saying about the pregnancy, three P's: pregnancy, period, and birth control pills. All of them are important here. You ask about the intimacy, which is very good question also. I want to add also one question related to the headache and the paracetamol. Whenever you have headache and patient on paracetamol, particularly long time, you have to know how frequency this patient is taking paracetamol.
Yeah,
Why?
for the analgesia induced.
Yeah, overuse drug, medication overuse headache. So you can mention it one of the causes of your headache. And also you have to rule out the causes or the manifestation or the symptoms or the signs of an increase in tachycardia pressure, which you didn't also ask.
The symptoms of, I'm sorry, of what?
Signs of increase in tachycardia pressure.
Intracranial pressure, yeah.
Yeah, is this headache worse with the leaning forward? Is
I
it
asked. I asked
you
this
asked?
question, yes.
Okay, it's important to ask them or any
Did
feeling
it change
sick.
with position? She
Yeah,
told me no.
not only position, leaning forward particular, because
Yeah.
you want to say this is not intracranial pressure headache.
Mhm.
Okay, okay. Any question, Dr. Salma or Dr. Amar?
No, thank you.
Yeah. Okay, Dr. Omar also asked here to offer the fundoscopy better. Yes, to say I would like to do, if I have time,
Yes.
to rule out papilledema. Okay.
Acuity
Otherwise,
and field and fundoscopy. What are you
sorry,
examining?
offer,
For
offer.
acuity, yes, and field,
Yeah, yeah.
and
He did the field already, right? The
yes,
Yes.
acuity, the acuity, you can start with it. You can see my fingers or for Snapchat if you have it, but if no, you can ask for the fingers. You cannot do the fields without asking for acuity. Okay,
yes,
because it doesn't make sense if you examine the fields if you don't know the acuity. How is it? If the
yes,
acuity is affected, how you can judge on the fields?
yes. I mean, that is all need to be checked.
Yeah, better to ask field the acuity before starting the field.
Yes,
However,
So
if
acuity and
you
field.
don't have time, you can just assume that I would like to the assess the vision through the Snell chart. Yes, Dr. Omar, what you want to ask?
for my differentialize, what I mentioned was the prolactinoma and pituitary adenomas other than acromegaly.
Yeah.
This what I offered.
Okay. As examination.
No, no, as a differential diagnosis, what I offered
Yes. Yes.
when I
I said yes.
pituitary adenoma and prolactinoma and then pituitary
Mhm.
adenoma.
Yeah, it's one of the differential.
But I
Since you
didn't
have,
mention the men as a bigger picture.
yeah, 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 yeah.
The
Men is in the top of your definition, and you have, especially
no,
in the
but
film,
she didn't have any other symptoms that was suggested. So this is why I
but
didn't
you didn't ask.
about the she doesn't have any features suggestive of hypercalcemia. When I asked about the polyuria and the thirst, uh, uh, And then confirmed it again when she was telling me that the GP has found that her blood sugar is a little bit on the higher side.
It's a matter of showing the examiner that you want to rule them out, even if it's not there, you can put it in
So
the differential. They like
what other question should I ask to
yeah,
in
tummy pain,
tummy pain? Okay.
yeah, or feeling acid brush because this
Mm,
gastrinoma will be associated with this,
mm.
and a gastrinoma one of the pituitary adenoma, right? Sorry, the
Pancreatic adenoma.
pancreatic,
Yeah.
yeah, yeah. Okay, I want to add the last comment for what I want to say. Yeah, the family history was negative, so you can say against that family history is negative. But if she said to you, "I am adopted," you can guess
Assume. Yeah.
or you assume this is a case of men. Okay,
Mm-hmm.
and they like this topic. The men, whenever you have acromegaly or any pituitary adenoma, they like to mention the men as a differential. By the way, acromegaly is a gift. If you have a case of acromegaly, it's a spot diagnosis case. Whenever you
That's
will
very
see the,
common.
it's common. You can see it. You can diagnose it whenever you see the patient. But don't forget to examine the face itself. This is the main features of acromegaly. In the hands, in the face, the
What
carpal tunnel.
examinations on the face specifically, like a
Perfect.
technique?
The frontal,
Because yeah.
you will see some frontal folds thickening, right? This is from the front. From
Uh,
the side, you will see the prognathism. The
okay.
mandible will be outward. The teeth are spaced. Okay.
Mm-hmm.
The tongue is big. The nose itself is big. And the neck circumference might also be higher or
Mm-hmm.
big. All of them can say, in general, coarse facial features, right?
Mm-hmm.
That's it. At
So
least you
the
have to
technique
have
the
a look.
technique in the exam would be to look from the front and from the side
Exactly.
to
Yeah.
give a
From the
comment. Yes,
perfect.
I'm talking about the show in the
Yeah.
show.
In the front and from the side.
Mm-hmm. Okay.
And ask the patient to protrude the tongue out.
Mm-hmm.
Okay. This is the way how to do it. They also the back or the shoulder for acanthosis nigricans. Some of them have it. Okay.
Mm-hmm.
Yes, this is my comment and the judgment. Anyone has a comment or question? Dr. Omar or Dr. Sama first?
I think it's okay now. Nothing.
Okay, Doctor. You read the comment quickly. Dr. Samira, I think that he must examine patient for cessation. Yes, this is carpal tunnel. Enhance and tests for carpal tunnel. Fennel test, you mean? Search for the signs of activity like sweating, skin tags, and for acanthosis. Perfect. Proximal myopathy. Examination blood pressure, random blood sugar, bedside is perfect. All of them are correct. Dr. Tahan, you need to examine hand for sweating, disease activity. Perfect. And this is a question, Dr. Omar. Don't forget. What are the activity signs or disease signs of activity? Do you know them?
Signs of disease activity.
Yeah.
Um, I'm not familiar with that question. I've never had this
Okay,
question before, to
we'll
be honest. Yeah.
ask this question to Dr. Selma.
Yes, you mean disease activity?
Yeah. Sign of disease activities.
Headache, uh, يعني uh, become more severe, the symptom.
No, no, no. They are three. You have to mention them by name. Sweating
Mm-hmm.
Okay,
and skin tags and hypertension.
okay,
Okay.
okay.
Sweating, skin tags, hypertension. Dr. Tani said the differential acromegaly, prolactinoma, non-functioning pseudoadenoma, Cushing, perfect. Men, please don't repeat the mistake. Men, you have to put it second one. Dr. Ala, first line treatment is surgical, yes.
Yes.
Sometimes they are starting with the medical just to reduce
To
yeah, or
shrink
to shrink the
the
size, then they go for surgery. There is two option of surgery, either transsphenoidal or transcranial. But nowadays they are preferring the
Is
transphenol
it
test.
is it usually by neurosurgeon or is it by ENT since the transphenodal approach?
Neurosurgery.
Neurosurgery.
Yeah.
Okay. Yeah.
The ENT might join, but mainly by neurosurgery.
Mhm.
دكتور علاء, nipple discharge should be asked for peritonoma perfect. If you suspect it, you have to offer it. Dr. Ala also offer fundus. Dr. Tahani diagnose isolated acromegaly or as a part from men 1. Perfect. So we are agree about this topic and about the first case. Anyone has question before starting the second scenario?
Sorry, Dr. Basim, it is curable?
Dr.
Yes.
Mahmoud.
Yes, it is curable.
Okay, what do you think?
Yes, it is curable, but there is chance of recurrence.
Perfect. Thank you.
So that is my will be my answer. Yes.
Yeah. This is
Anything
your
in
question?
medicine, there is anything in medicine, it has a chance.
Yeah, but sometimes the surgery will help you to cure the disease and the manifestation. Whenever you remove it, so you cure the
The
disease.
visual.
Everything will be cured. Supposed to. But I want to say there is possibility of recurrence, as Dr. Mahmoud said, and of course the recurrence rate is
One
good.
question,
Yeah, is high.
One question
Yes.
we missed is the change of sensation of smell. Because it is common with every pituitary glands that
I'm not familiar with this. I didn't hear about
it's
it.
not common.
Okay.
I'm talking about this not from personal experience. One of my friend who had prolactinoma, the first thing that he was noting before the visual symptom, because he used to work with us, was that he's not smelling very well all of a sudden for 1 week, and then on a glance of a night when he woke up, he had some visual symptoms.
Okay.
But I'm not. It's not in the book, but it's not a bookish thing. Like it's not within the books that you have to ask for this, but this is something that I just remembered right now.
Okay. I'm not sure also about it. Anyway, let's.
Possible.
Any other question before starting the next scenario?
Yes, Dr. Basim,
Yes.
regarding non-functioning pituitary adenoma, how it came in the exam as a history. What is the specific question I want to ask about it?
Non-functioning pituitary adenoma means there is adenoma compressing the pituitary itself, right? So the deficiency will be the other hormones. Other hormones will be low.
It will lead to high prolactin level. Yes.
Amenorrhea and the addition, hypothyroidism, and the compression signs.
Like يعني pituitary apoplexy يعني
Yes,
مثلا.
the same presentation, yes.
طيب why it called non-functioning? Does that mean functioning if it affects the hormone?
It doesn't secrete.
Not as excrete. Yes, not excess. It's low.
It compresses on the pituitary stack, so it will prevent the dopamine suppression of prolactin. Therefore, the prolactin will be a little bit on the higher side, but not as high as the prolactinoma. Not as by 1,000. It will be above normal, but not as 1,000. Why? Is that because the non-functioning pituitary adenoma will compress on the stalk that contains the tubulo-infundibular dopaminergic pathway that is mainly inhibiting the prolactin to be released from the pituitary. This is the only hormone that it will be deranged in non-functioning, but the tumor itself doesn't secrete any hormone. This is why they called it
this is the main
non-functioning.
reason of the name. Non-functioning means no hormones are excess secretion, or it's not excess secreting adenoma. It's decompressing and makes other hormones less or low.
Okay, thank you.
Yeah, it's different from prolactinoma, which high prolactin, Cushing, high cortisol, and our case today, acromegaly growth hormone. Okay, thank you. Yeah, we can start the next scenario. Mr. Robert Stanley, 32 years old man. The sitting in gastroenterology outpatient clinic. The role, you are the doctor referred by the GP following abnormal liver function test detected on recent blood test. He has also reported recent onset itching. He has a background of diagnosis of ulcerative colitis. The most recent colonoscopy demonstrate extensive colitis with moderate to severe inflammation. Blood pressure 120, heart rate 68, temperature normal, oxygen saturation 98, no room air. Blood test ALP high, alkaline phosphatase ALT 88, high, bilirubin 21, upper limit. Albumin normal, INR normal. Your task is to take a focus history and examine the patient, address the concern. Dr. Salma, whenever you're ready, we can start.
So again, Dr. Bassem, for the focused examination acromegaly case, how we started?
You start from the hand
Okay.
as vitals. Okay, ask for blood pressure, blood sugar, heart rate, and the
Sweating.
blood sugar. Okay, then
Mm.
the hand sweating. Yes,
Mhm.
in the palm. The skin at the back, dorsum of the hand, skin tags all over the forearm and hand, then the finger prick marks for the blood sugar check, and the carpal tunnel you have to offer before starting it. Do you have any pain in your finger whenever I tap here?
Mhm.
Then you can tap. If there is no pain, if there is pain, offer and ask permission from the examiner. If he's
Mhm.
agreed, proceed. If not, no need. Then you asked for blood pressure earlier, right? Proximal myopathy
Yes.
signs, proximal myopathy,
Mhm.
and at the back of the shoulder for acanthosis nigricans, any hyperpigmentation. Then the face for, as I said, the facial, coarse facial expression by examining the front for the frontal or the skin folds at the frontal area.
Mhm.
Then for the nose size, you can just observe, not don't touch. Okay, just
Mhm.
looking at the face. Open your mouth, tongue is out. Then come beside the patient, ask him to protrude the tongue and check for prognathism. Usually the mandible at the level of maxilla, but in the acromegaly, the mandible is outside or in front of the level of maxilla or the upper jaw compared
Mhm.
to the upper jaw. Yeah,
Mhm.
the pulse. I forget to mention the pulse at the hand. You can find high output or
Yeah.
high volume pulse, right?
Yeah.
Yeah. Then the heart examination, as you said, or the cardiovascular examination. The apex speed, is it displaced? Sometimes with the hypertension, it might be displaced, or murmur, sometimes functioning murmur because of high output. And the bibasal crackles at the back. Don't forget
Mhm.
the breast if there is acromegaly. Sorry, if there is gynecomastia,
Yeah.
but it's not the case today. I mean, abdominal examination. You can check for organomegaly.
Acromegaly.
Sometimes there is hepatomegaly, splenomegaly, or amyloidosis for the palatable kidneys. Then the what else? Yeah, the bowel sound if you can offer or if you have time.
Mhm.
The eye examination, of course, for the biotimber hemanopia, you have to mention or you have to do while doing the facial examination. The legs for osteoarthritis, the knees for crepitus, so you can ask for passive movement and you can feel the crepitus.
Mhm.
And by the lower limb edema, is it pitting or not?
Mhm.
By the way, any case, you have to do train on the examination of this case, either on someone or your partner or even family member.
Mhm.
For example, acromegaly, one of the case are very high yield, right? So
Yes.
it might come to you in the exam. Try to do
Mhm.
these examination steps on anyone you know. Just
Mhm.
simulate in this way as repeating them if you have time, if you have another time. By the time you will be memorizing all the steps by heart. This is
Mhm.
the good advice to do.
Mhm.
Not only the acromegaly, the rheumatoid arthritis. All the disease have the
Specialty
manifestation.
specific.
and specific presentation. And it's a very high yield topic, common to come in the basis. You have to do it in not on daily basis, but at least before the exam 3 or 4 times on anyone you know, partner or your family member.
Yes.
Okay.
Okay. Thank
Yeah.
you. Yes.
Most welcome. Anyone ready? Sorry, Dr. Sama, ready to start?
Yes.
Yeah, here you go.
Okay. Uh, Hello.
Hi, hello.
I'm Dr. Ahmed. I'm doctor in the clinic today. Can I confirm your name and age, please?
Hi, I'm Stanley. I'm 32, yeah?
Nice to meet you. Today we are here to examine you and address your concern. Is it okay with you?
Yeah.
Okay. Please, Mr. Robert, can you tell me what bring you to the clinic today?
Well, I've been referred by my doctor because my liver function is, he was worried about it when I came to him because I had a little bit of itchiness, which has started in the last 4 to 5 weeks. Um, yeah.
Okay. Okay. Uh, Now your problem is itchiness. Can you tell me more about this itching?
No, it started out of no reason. I'm not allergic to anything. I'm not
For how
uh,
long?
4 to 5 weeks, last four to 5 weeks, to be honest.
Okay. Okay. All over body?
Yeah, there's no specific parts on the body, but yeah, that
Okay.
started to wake me. I'm itchy most of the day without being exposed to anything. So I went to the GP and then he uh, did some blood tests where he found that my liver function is not good.
Yes. Yes. I'm sorry for that. Uh, can you tell me more about itching? Is it more at night or at the day?
No, I didn't notice that.
Okay. Is this first time to happen?
Yeah,
Okay. Okay. Is there any other symptom you feel
no,
like upper tummy pain?
no,
Any yellowish discoloration in your
no,
eyes?
no.
Any symptom of loose motion?
Um, no, no, it is my symptoms are well controlled, to be honest, for the last year. Last year I had 2 flares, which was managed by the IBD nurses in the clinic. I didn't require any hospital admission.
Okay, good,
My symptom is well controlled.
good, good. Now, no, any symptom of upper tummy pain or tummy distension. No
No, no,
fever.
no fever. Thanks. No.
Okay, I mean high body temperature. Okay. No any change in your weight.
No,
Okay. No, is there any loss of appetite?
no,
Okay. Your bowel is okay. No change in your bowel. No,
uh,
no.
no.
Okay, okay, okay. Is there any change in your color of stool?
Not that I noted, to be honest. No,
Okay, okay. Is there any change in your water work?
no,
Okay. No for the urine.
no.
No change in the color of the urine.
No,
Okay. Is there any chest pain?
no.
Okay. Any heart racing?
No heart racing. No,
Any shortness of breathing?
no,
Any coughing or coughing up of blood?
no,
Okay. Uh, any headache?
no.
Any memory problem or vision problem?
No,
Any feeling of tingling or
No,
abnormal sensation?
no. But I started to have like 6 months ago, my back started to feel a little bit some my lower back specifically. I did have some pain that it's there in the morning and then uh, uh, improves by the end of the day.
Where is the exactly pain?
No, it's in my lower back.
Okay, I'm sorry for that. For how
No.
long?
It started 6 months ago.
Okay.
Yeah.
Um, okay. Is it severe if you grade it from 0 to 10?
It's not severe now. It's a little bit of this, maybe 5 out of 10. You can tell.
Okay. Any aggravating or relieving factor?
No, it improves when I move only.
Okay. 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 And now you feel any pain?
No, not at the moment. No.
Okay. Okay. Is there any change? You feeling any change in weather preference?
No,
Any neck swelling, anterior or
no,
any? Okay. Okay. Um, is there any joint pain other than back pain?
no.
Okay. Is there any skin rashes?
No,
Okay. Um, uh, any past medical history should be aware of?
no. Apart from ulcerative colitis, no.
Okay. Ulcerative colitis for how long?
It's now been for 15 years.
Okay. You are on medication now for ulcerative
Yeah,
colitis?
I'm taking mesalazine, yes.
Okay. Okay. You took this medication now for 15 years.
Yes, I'm on mesalazine, yeah.
Okay. You take this medication regularly?
Yes.
Mm. Any
My
change in
last follow-up was 2 years ago when I had the camera test.
okay.
Hmm.
Any change in medication dose?
No, no. I usually follow up with the nurses in the clinic. Yeah.
Okay. When last time flare up of ulcerative colitis?
I had two flares last year, as I told you. About it was managed in the clinic. I didn't admit it in the hospital.
Okay, that is good. When last one?
Um, both were happening last year, so maybe 9 months, more than 13 to 14 months ago, the last one.
Okay. And you didn't admit it in the hospital?
No.
Okay. Only treated as outpatient.
Yeah,
Okay. 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 Any other over-counter medication?
no,
I'm sorry for this question. Any recreational drug use?
no,
Okay. Any other past medical history should be aware of?
no. I
Any
don't have any other medical problems.
any family history?
There is of cancer colon.
Okay. This is how long before?
How long before what?
I mean, you have
Sorry, I
cancer
didn't
colon.
follow. No,
Yes,
I'm
you
not
have.
having family history. You've asked about family history,
Okay.
doctor.
Yes. Yes, you have family history of
Yeah,
cancer colon.
yeah.
Okay. Is first degree first degree? Your
Yes,
father,
yeah.
your mother?
It's my father, yeah.
Okay. Now it's okay?
Yeah,
Treated?
yeah.
Okay. 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 Can I ask some social question? What do you
Yes,
do for a living?
I'm a teacher.
Okay. Um, are you financially supported?
Yes,
Do you smoke?
yeah. I do smoke like around 10 cigarettes a day.
Okay. Okay. There is some theories that smoking is, as general, smoking is harmful, but in
Mm-hmm.
your condition, there is some study that smoking can little help in your condition.
Yeah, to be honest, this is why I noted myself. I didn't know about this, but yeah.
Yes, yes. Is there any uh, you drink any alcohol?
No, I stopped drinking 15 years ago.
Okay, okay. Is this symptom impact in your life?
The itchiness, you mean?
Yes,
It's yeah, it's making my life difficult, yes.
yes. So we can give you sleep until we fix your problem.
Mm-hmm.
Okay,
Yeah.
okay. Okay. Can you let me to examine you, please?
Yes, of course.
I want to see hand.
Yes, hand. There's no obvious abnormality. Is there any specific thing you would like to examine for?
I mean, any clubbing, any
No, no,
conychia, lymphanica, any
no,
primary erythema, any
no,
uterine contraction, any
no,
fine tremor or flapping tremor.
no,
Okay. Then I will check hand, arm for any fistula.
no,
I will check axillary hair.
normal,
Normally distributed. Okay.
normal.
Then I will examine eye for any color jaundice.
Normal.
Then I will examine mouse for any central cyanosis, any mouse hygiene for
Mm, normal
gingival
look.
hypertrophy.
No, normal look.
Okay. Then I will check for JPD.
Normal.
Okay. I will. Is there any tummy pain?
Not at the moment. No, there's no.
Okay. I will do hepatojugular reflex.
Normal.
Okay. Um, I will do abdominal examination.
Mm-hmm.
Okay. Inspection.
Normal. There's no distension. Normal contour of the abdomen. Can you hear
Okay.
me, Dr.
Is
Salma?
there
Yeah.
any? Yeah, yes. Is there any scar? Or is there any
No,
scar
no,
for
no. No
previous
scars.
surgery?
No, no, no scars.
Okay. Okay. Then I will examine for organomegaly.
No bulbable organomegaly.
Okay. Um, no, any colostomy bag, no, any surgery
No,
before.
no,
Okay, no organomegaly.
no.
I will do percussion to check for liver span, and also I will
Mhm.
I will do also uh, spleen. I will check for spleen size and for
Mm-hmm.
kidney bilateral palatable
Mm-hmm.
kidney or
2 minutes
Normal.
left.
okay. Is there any lower limb edema?
Nope.
Okay. Is there any sacral edema?
No.
Okay. Um. Okay. No lymph node enlargement.
No.
Okay. Thank you for let me to examine you. Do you have any concern?
Well, yes, doctor. Um, why my liver test is abnormal, and, and why I do
Yes.
have this despite
Okay.
I'm well controlled. I'm taking my medications for the ulcerative colitis, and everything should be normal.
Yes. Yes. I highly appreciate your concern. From a symptom and of itchiness and examination. You have a condition called primary sclerosing cholangitis. Don't bother by this name. This is an autoimmune condition. That means defect in your immune system, and
Mm-hmm.
this always happen as a complication of your primary problem of ulcerative colitis.
Mm.
Yes.
So, okay.
This condition. What happened for this condition, primary sclerosing cholangitis, is scarring of the bile duct.
Okay. Doctor,
Yes.
does it increase my cancer risk chances? Because I'm usually mild ulcerative colitis increases my bowel risk cancer. Uh, does this increase my risk for cancers?
Yes, as generally ulcerative colitis, as generally you have high risk to develop
No, no,
cancer,
I'm talking about
unfortunately.
I'm talking about the disease you are suspecting.
Um, Disease itself can be, but the condition is more, or the main problem of ulcerative colitis make you more prone to uh, cancer.
Okay.
Yes.
Okay, time is up. Examine question.
Uh, Thank you, doctor. Could you please summarize this case?
Okay. Okay. Uh, uh, 30 or um, yes, 32-year-old
Mm-hmm.
male presented with itchiness
Mm-hmm.
all over the body, um, in a background of uh, itchiness for 5 weeks all over the body, with a background history of ulcerative colitis for 15 years on mesalazine, um, and has is controlled as ulcerative colitis with the last period uh, uh, 1 year ago,
Mm-hmm.
and has
Uh,
a family history of colon cancer also in the first degree relative.
okay. Any positive finding?
Uh, uh, on examination, uh, no,
No.
yes, a
Okay.
normal abdominal examination. Yes, no
What's your
jaundice, no
differential?
pallor. My differential diagnosed primary sclerosing cholangitis,
Mm-hmm.
as a failure of ulcerative colitis. Um,
Any other differentials?
um, uh, I
The patient mentioned
the,
that he is having some back pain. How do you think
yes,
it's related to, do you think it's related to his condition?
maybe have ankylosing spondylitis.
Okay.
Uh, Also for itchiness,
Mm-hmm.
um, uh, can be as a medication side effect.
Okay. S-
Um,
uh, do you mean that
uh, pro-
for your differential diagnosis?
yes, yes,
So drug induced.
yes,
Okay.
yes. Can be urticaria.
Okay.
Yes.
Uh,
Can be also by, but this is against this one, can be biodermal gangliosum, but against this one, itching all over the body.
mm-hmm.
Okay,
Mm-hmm.
I think
Uh,
that's all I
for
have.
the urticaria, have you found any positive findings supports the urticaria?
No, only as a
Mm.
differential of
Oh,
itching.
yeah. Okay. How you would like to investigate this gentleman?
Um, Apart from general investigation, full blood count, renal function, and liver function test, and inflammatory marker, CRB and ESR. Also need to do MRCP.
MRCP, okay.
Yes.
How would you like to manage?
Um, manage. We will manage itching by giving um, cholestyramine to relieve itching,
Mm-hmm.
and and also stenting,
Mm-hmm.
PRCB.
Mm-hmm. Regarding this gentleman's follow-up, he mentioned that his last follow-up was 2 years ago. Would you like to add anything about his follow-up plan?
2 year or last 1 year, when flare up.
Yes, and
Uh,
his OGD was showing extensive, moderate to severe inflammation.
okay. I'm advising for more follow up.
Yes. How frequent?
Yes. Um. Uh. Should be regularly. If there is any new symptom, uh, should advise medical advice before time of the follow up.
Okay. Uh, is this patient at any other cancer risk?
Yes, this patient is a highly risk for cancer apart from ulcerative colitis, primary sclerosing cholangitis, and strong family history of colon cancer.
Other colon
So
cancer,
need to
other than colon cancer.
other than colon cancer. um, than colon cancer.
Okay,
No problem.
6 minutes. Any other question you want to add?
It's just one more question.
Okay, okay, continue.
One final question to cover this topic. This gentleman, you've mentioned you would like to do a full blood count. Is there any rationale for monitoring full blood count for this patient, particularly in this case?
Sorry.
In this patient, what's the
Uh,
importance of reviewing his full blood count?
it's very important.
Hmm.
We will check for HB and for also total white blood cell.
And why is that important?
Uh, for uh, to know flare up of infection.
Okay,
Yeah, if there is high total, just
okay.
yes,
Has it something does it have anything to do with his mesalazine, as this patient is on mesalazine?
yes, yes. Need to check for pancreatitis.
Yes, of course, but I'm talking about white blood cells and mesalazine.
White blood cell and mesalazine.
No, it's fine. It's
Cause leukopenia.
yeah, agranulocytosis. Yes,
Okay,
any patient on mesalazine should be followed up also with to be checked with full blood count. Anyway, thank you, Dr. Salma.
thank you.
Yes, you can comment now again based on the skills in the chat box.
Okay, let's start with physical examination. I think physical examination was satisfactory. I think the only thing that you've missed is to check for pyoderma gangrenosa of the skin, but it would be obvious when you test for lower limb edema, unless the patient is wearing trousers or anything that would conceal the pyoderma gangrenosa. Identify the findings. There was no finding in this case.
Also erythema nodosa. Both.
Erythema
I
nodosum,
forget
yeah, and
both.
pyoderma.
I forget both. Yes. Okay.
Yes, but in reality, sometimes in reality you will be seeing the lower limb. But anyway, if it's concealed, remember to uh, look up into them. Clinical communication for in terms of relating things in history. Medication has been asked, past medical history, it's been asked about for how frequent. Symptom control has been asked. Job, smoking. And then for clinical judgment, it's satisfactory. Yes. Your differential, um I would give borderline, to be honest.
Yes,
Um
I feel that more.
um, you thought of primary sclerosing cholangitis, and then later on you've added drug-induced. In your history, although you've asked about the risky behavior, which you already have asked, sorry, that you have, do you do any drug use or things? So you need to, this is, you can use it to justify that this less likely viral hepatitis should be on the differential. So for the investigation, this is in the clinical judgment. You didn't add the viral hepatitis. Usually, it would be added in the investigation panel for investigating someone with deranged blood. Concerns. There is one of the concerns that I don't know. Although I reiterated this in my questioning, it's about the risk of cancers. There is two risks of cancers. Cholangiocarcinoma would be and colon cancer in this patient.
Yes, and also I forget also hepatocellular carcinoma can be also.
No, hepatocellular carcinoma is with primary biliary cirrhosis. But the main two cancers with in this patient, in this case, cancer colon and cholangiocarcinoma. What do you think, Dr. Salma? Which risk is higher in ulcerative colitis patient?
Uh,
Who
Colon
does
cancer.
whom? Yes, but when you once you've suspected primary sclerosing cholangitis, I think both can happen, but the more he's at more risk of cholangiocarcinoma more than cancer colon, but he will be surveilled for both.
Okay.
Okay. You've missed ultrasound abdomen. Usually you start with ultrasound. On our level, we request ultrasound and then refer for MRCP.
Okay. Yes. Yes.
Um, welfare, you've managed the welfare. The welfare was satisfactory.
Okay, so you can comment now on the topic.
On the which topic? The physical
The case
examination.
itself, the case
Oh,
itself.
okay. So this case is
Yeah,
is
what she missed in the case as a finding and as a
uh, the eye. You didn't ask about eye symptoms, which is a common extra bowel symptoms. You've asked about the skin rashes. Do you, Dr. Salma?
Eye
Can you hear
symptom
me?
other than jaundice.
No. The eye symptoms in the patient history when you are taking history and you
You
do the
mean
review of system.
uveitis? Yes, as
Yes,
associated condition. Yes, yes, yes,
yes.
sir. Yes.
So
Okay.
what's the extra intestinal manifestations of
This
ulcerative
I will ask it
colitis?
as a red eye or what? Red eye.
Yep. And what specifically, if you know, with ulcerative colitis? It's usually
Uh,
uveitis,
yes.
and Crohn's does have episcleritis, which is painless.
Yes.
Sacroiliitis is a common in ulcerative colitis, which is why he's having the back pains.
Okay.
For so this case is connecting testing the connection again between ulcerative colitis and primary sclerosing cholangitis. Both are common. Do you know what's the usually from a prospect of ulcerative colitis, 4% of the patient does exhibit primary sclerosing cholangitis. In terms of follow-up, because this is very important, Usually, any patient who does have extensive, which is extensive does mean, which has been written there for a purpose, extensive, which means that he had the entirety of the colon, his whole colon is inflamed, and the degree of inflammation is moderate to severe, then he should be on a yearly follow-up. And he does have other family member who does have cancer colon, and he does have also the primary sclerosing cholangitis symptom, suggestive symptom. So he wasn't on, he wasn't being followed up appropriately. He should be on
Yes.
yearly because his last OGD was done 2 years ago. You didn't explore why he didn't with him, even though if the history could feel lengthy, but you can reflect on that when you are commenting on the case with the examiner. This is a case of a possible primary sclerosing cholangitis and a back because the patient does have a background of XYZ of ulcerative colitis, and it has been there for 15 years. It's although that it's well controlled recently and the patient doesn't have any symptoms, he had uh, an OGD which was done 2 years ago, suggestive of extensive, moderate to severe, which he needs to be followed up more tightly for cancer surveillance. Cancer surveillance is one of the important things that should be commented, and it's expected if this case was not for diffuse history. So the history should be the history that we should comment on in my calibration is usually the how frequent is the follow-up. You've asked correctly about when was the last flare-up, are you taking your medication regularly, and you've asked about the cancer colon in his family history. For the concern, we've touched back with the cholangiocarcinoma. For the differential primary sclerosing cholangitis, you can give primary biliary cirrhosis, but it's less likely. It's common in female, viral hepatitis, and drug-induced. Autoimmune hepatitis would be less likely in males, usually in general. So the three, primary sclerosing cholangitis, you can give the other two, the primary biliary cirrhosis and the autoimmune hepatitis, but viral hepatitis should be on your second and then on third drug-induced, especially that he's on mesalazine, although mesalazine is not known to cause cholestatic picture. If you have the knowledge about the medication that would affect that would cause cholestatic picture, such as recent steroid use, recent antibiotic use, it would be nicer to be asked in the history, have you been recently on an antibiotic on any recent steroid course? He would tell no. Is that
Yes,
has that
okay, doctor.
explained?
Yes, I want to ask about follow-up point. Should be
Yeah,
every how long?
every one
This
year.
patient is stable and no
Every 1 year. So this
every 1 year
patient,
for follow-up.
every 1 year for cancer colon surveillance.
Okay, for cancer colon.
So for the follow-ups in inflammatory bowel, the follow-up rules is number one, if the patient is low risk, intermediate risk, and high risk. Low risk, he will be on 5-year follow-up. Does someone who doesn't have active inflammation on his last OGD. His no active inflammation, no family history of anything. So he's been on the low risk. Intermediate risk, he does have mild inflammation. He will be on 3 yearly. But someone who does have moderate to severe, extensive is the represent the extent of the inflammation within the colon itself, because it's if it involves the left, the right, ascending, the transverse, and the descending. This is the entire colon. Alone, this should be putting him on 1 yearly follow-up, but there is 2 or 3 things: family history of cancer, and the family member is had cancer discovered less than 50 years, when he was less than 50 years old. And of course, if he does have primary biliary cirrhosis or any signs of sclerosis, he could have primary sclerosing cholangitis, or as biliary sclerosing uh, in the biliary tree, which again itself, it should put him on a yearly follow-up. So you do have 3 reasons to consider this patient for yearly follow-up.
Okay.
Cholangiocarcinoma risk is 10% in this patient, which is higher in than his cancer colon. But he's at risk of both.
Okay.
Okay, thank you, Dr. Amar. It's a nice case. It's common also ulcerative colitis associated with the PSC, primary sclerosing cholangitis. So always put it in your differential, Dr. Salma, and I think everyone knows the differential. Primary biliary cholangitis, formerly was cirrhosis. Also one of the differential. I just refreshed and googled the mesalazine can cause cholestasis. Yes, it can cause. So you can put the third. This is also my
Drug-induced.
drug induced. Whenever you have patient on medication, even if you don't know, if you are not sure about the side effects, you can mention it as a drug induced. Here, the cholestasis, mesalazine itself can cause it. So you can mention it as a differential, okay? Always, as I said, it's joker. You can put it whenever the patient is taking either polypharmacy, more than 5 medication, or if he's taking medication and you don't know more about this medication, put it as a third differential. Autoimmune, yes, you can put it as long as she's female. Otherwise, it was good history by Dr. Salmarili. She asked about most of the things, the complication, the skin rash, but the bioderma gangrenosum most common associated with ulcerative colitis. The back pain, I believe you have to take more history about the back pain, enteropathic spondylitis, not ankylosing, doctor, not ankylosing spondylitis, doctor.
Yeah.
Yeah,
Yeah.
Salma. Yeah, okay.
Yeah. Yeah.
So it's enteropathic type spondylitis. The other thing, drug, yeah, the good history. You ask also about the colon, family history, the colon cancer, even the history of. I like also this question when you ask about had a flare with what was the last time, any medication added, the compliance of the medication. All this question was good and targeted.
Yeah. What mesalazine, whenever the patient is on mesalazine, uh, you shouldn't forget about the agranulocytosis. Whenever you had sore throat, whenever you feel unwell, you should safety net the patient about this all the time. This is also a
Okay.
very important thing to be acknowledged. They do like to hear that. Mesalazine, the causes of the agranulocytosis, um, it is here. Just 1 second. Agranul. Uh, the carbamazepine, the clozapine, the mirtazapine, carbimazole in as an antithyroid drug, penicillin, chloramphenicol, and methotrexate and mesalazine. Usually, those patients, um, uh, you should safety net the patient about the agranulocytosis.
Yeah, thank you, Dr. Ala. He reminded me about smoking. Dr.
Smoking, yeah.
Yes. I want to ask about
Yeah,
this point.
it's good
You sh
information, but you
mm,
shouldn't advise
encourage.
education or
Oh,
encourage.
yeah.
Yes. Yes.
So I
I think
think I put in the welfare. I can say it can minus you. I don't know if I put it borderline or no, but it's or clinical judgment. Yes, in the clinical judgment, don't mention the smoking is helpful for any condition, even if it is. But in general, it affect and harm the health, general health. Never ever
okay.
say to a
If
patient,
in like this situation, how I can answer this question as
yeah, you can say
I
it's,
answer generally, regardless of the benefit in ulcerative colitis, or
I will tell
what
you
I
now.
will.
So, first
Okay.
of all, you appreciate his knowledge. Okay, appreciate that he knows that. I appreciate your knowledge regarding this information. You're right. Theoretically, it it can reduce the symptoms. However, in general, the smoking is harmful for your condition, and it might lead to certain cancers, other health problem, lung and other cancers also can be related. Not only the lung cancer. So I would like to advise you to stop smoking. This is the answer.
And to be honest, I didn't
Okay.
mention that
But if you
unless
stop it,
Dr.
will
Salma,
come with flare.
yeah, I did,
Whatever,
yeah.
even though
Okay.
it's not
Okay.
advisable one.
Okay. As
Okay.
general.
Yeah, Doctor, what you want to say?
No, I didn't mention the smoking. I've noted that the smoking has benefited me, unless Dr. Salma herself uh,
Yeah,
commented.
but I mean,
After that comment, I
yeah,
mentioned, yeah, I've noted
you
that.
admit this. Yeah,
Yeah, if she didn't mention, I wouldn't be saying anything.
yeah.
This is one of the things that I wanted to ask toward the end. Thanks, Dr. Ala, about reminding me. So, in this situation, Dr. Bassem, we will say basically smoking in general does have its own risk. Uh, we can't encourage you to smoke, but if you if the patient concern, oh, I don't want to stop smoking because
Usually,
it's improving my,
it comes as a concern. He is the one raising it as a concern. Doctor, I read about smoking. It can help to subside my symptoms.
it would be in
Is
a
it correct?
communication station, yeah.
Yeah, sometimes, or the concern at the end of your session. I mean,
Mm,
one of the concern at the end of the station. Doctor, I have question. I read about smoking. It can help to reduce my symptoms. Is
mm,
it? So you can say yes, appreciate that. Then go ahead. Okay. جيب واحد. Go ahead.
okay.
Okay, in this way.
But if
Yeah. Anyone?
patient is not start first to target this point, from my side, I didn't mention it. Better to
Yeah,
not
no, no, no,
mention.
no.
Is it better
Never
or no?
ever mention it unless he raise it.
Okay.
Okay. Don't say
Okay.
because he will get it as a excuse. Okay, doctor. So it's good. I can smoke,
Yes. Yes.
and it will
You see, in this
affect
case,
you.
he like
Yeah,
when I see. Yes.
yeah, that's why. Okay. Yeah. Anyone want
Okay.
to comment?
Yes, Dr. Bass, I heard about the concern of smoking. Very good answer. We have treatment can help you about your disease, which is ulcerative colitis, but smoking is a bad for your health.
Yeah.
You want to answer like this? You mean?
Like this, Dr. Basim, yes. And according to this case, Dr. Basim, I have comment on this case, Dr. Omar.
Yeah.
Yes, sure.
Yes, because this case came before in the exam. And
Mm-hmm.
the main issue in this case, it is not easy case because alkaline phosphatase 420. So it is obstructive.
Yeah.
First we have to mention more likely it is in this case, the surrogate tells that I have lose weight 10 kilograms and loss of appetite. So first we had to put test cholangiocarcinoma and the primary sclerosing cholangitis. Not like hepatic HCC, not like drug induced, because this not obstructive. It is hepatic injury. So in this case, came to know about obstructive
Jaundice.
jaundice. Yes. So
Yeah.
first differential diagnosis will be yes, cholangiocarcinoma versus primary sclerosing cholangitis. So we had to do MRCP, ARCP, MRCP, ERCP because also in the differential diagnosis we put stones. So we had to do MRCP, ERCP to know, and also X-ray to know if there is any toxic megacolon, any perforation, like that.
Yeah, but this case when it came here, the patient doesn't have as per my friend, you know, he didn't have any symptoms of
Yes, it came in
uh,
Qasr Al Aini. I think the same diet with me. It was the same case. Alkaline phosphatase was very high.
mhm.
So I listened to Dr. Ahmed. He did this case. He said like that. It is obstructive jaundice for differential diagnosis.
Yes. So
Not
the patient, they use the scenario, they twist the scenarios differently, but in here in the last diet it didn't came with here in UK it didn't came with weight loss. So and the patient is young, he doesn't have any symptoms of like warning symptoms. So no need to suggest cholangiocarcinoma now, as the patient you will give the differential diagnosis for cholestatic jaundice.
yes.
Okay, let's
Like
clarify
Dr.
it.
Bassem, yes, BBC
Yeah.
not alkaline phosphatase not increased in BBC. Uh,
Yeah,
so
yeah.
the, yes, so the
Mainly
mm,
liver, yes. Mainly
yes, Dr.
hepatic.
Bassem.
Okay.
So my
But still the
differential I
jaundice can
said,
happen.
yeah, it is primary sclerosing cholangitis, viral hepatitis, and drug-induced. This is what they, this is what what my colleague,
Viral hepatic, mainly hepatic.
yeah,
Uh, he alkaline phosphatase came in this case to um, uh, to know what is the obstructive jaundice, not hepatic, extra hepatic. I
yes,
think this is the aim of both alkaline phosphatase very high in this case.
hmm yeah,
Okay, so you are more target to the investigation.
Yes, mm, yes,
yes.
Dr.
So
Bassem.
this is why he offered ultrasound to rule out any extra hepatic biliary tree, and then referred for MRCP.
Yes, Dr.
This is what he told. This is what he told me. So
Mhm.
Good point. Thank you, Dr. Mahmoud.
yeah,
But
Thank you.
again,
Dr.
the BBC also can present with the jaundice and itching, right?
Yes,
Yes.
Dr. Bassem, but not increased alkaline phosphatase.
Okay. You mean the investigation itself? Okay, okay.
Yes,
Okay,
because he
you
put
can mention it. You can mention it, and you can say
Again,
against
is
that.
that?
Yeah, the
mm,
alkaline phosphatase in this case will not be high, or compared to this scenario, or to compare to the PSC, primary sclerosing cholangitis. But good point to mention. Thank you, Dr. Mahmoud.
thank you, Dr. Bassem.
Yeah. Okay. Any other question or comments? Anyone want to add?
Actually, thank you, first of all, for this great and informative sessions. The good thing you catch the smoking, because I catch the smoking. I said I hope they will comment upon this, because the doctor, when she said like this, she's acting like she's so happy that the smoking can relieve something like that. But in medicine, smoking in every case is the risk is outweigh the benefit. Although the benefit here in this ulcerative colitis is not due to smoking itself, due to the nicotine and the effect of nicotine that affecting the centers. Regarding her performance to me, she feel just lost in the clinical communication when there is nothing to say about, because she found already deranged liver enzymes with itchiness. So for some moments she don't know, or she doesn't know what she will do in the clinical communication. And for me, in she did not put a quiet differential diagnosis to look for in regarding the differential diagnosis. When she said the background of ulcerative colitis, she just put only in her mind primary sclerosing cholangitis. She forget the others, like what you said, the medications, the stones, the malignancy. And there is another possibility she should. So also the disease explanation, I think she used some jargons in the explanation, and also I did not hear what how she will admit this patient or not, and which specialty the patient will follow. I did not hear, or maybe I missed that when I went. And this is also I did not hear that about the clinical judgment and the disease explanation regarding that. But in general, she did great.
Yeah, thank you, Dr. Mahjoubi. Really, your comments are good, always to the point, whenever you are attending with us. So, yeah, right. Sometimes she's using jargon, and I believe she also has some hesitancy while asking or commenting or answering him. Not only that, she lack a lot of confidence. She need to be more confident while answering the questions of the examiner. She mentioned one of the differential only, as you said, and take time to present the patient manifestation from the 20-second waiting or to remember. Try to recall the patient age. Dr. Selma, whenever you are presenting,
Yes,
if you cannot remember, no need to mention exactly how old is he. You can say middle-aged patient or elderly or this gentleman. No need to mention it if you cannot,
Okay.
because it's 5 minutes exactly, no more one even second. Once the bell will ring, you will not have any chance even to talk. Okay, they will tell you, okay, time's up.
Yes.
So the 20-second here while presenting, whenever you are missing this part, it will affect one of the question, either the clinical judgment, investigation, the management plan, differential diagnosis, and the signs and symptoms. So either any of them will be lacking in your mark, and of course it will affect all the skills. Okay, so don't take time to answer. Be more confident, and I think you have good time to practice. Whenever you are practicing and training, you will gain this confidence. Okay. Thank you, Dr. Mahjoub. Anyone has another
Thank you.
comment? Yeah, thank you, Dr. Salim. We will go to the comments. First of all, examine all extra. Yes, the eye should be examined for anterior uveitis, as Dr. Omar mentioned. Need to examine for skin rash, Dr. Tahani, bioderma or erythema nodosum. Yes, you have to explore the leg or to ask, and if you have, you can examine. Then the differential primary sclerosing, primary biliary cirrhosis, Dr. Tahani, fat soluble vitamins as yes, as a management in the management, adding to your steps of management. Cholangiocarcinoma, Dr. Muhammad Bas, I think, or you I cannot know the name exactly. Anyway, cholangiocarcinoma, yes, this is the most target cancer you have to mention. PSC usually complicated by this cancer, cholangiocarcinoma. So you have to know it. Dr. Samira, treatment include more control of ulcer colitis, also deoxycholic acid to improve liver function, cholestyramine for fat soluble vitamins, supplements. For the bilirubin, you mean cholestyramine binding, okay? Fat soluble vitamin supplements, prophylaxis against osteoporosis. I don't know if she asked about HIV and hepatitis to as risk factor. You mean risk factor or risk habit because can raise the liver enzyme, of course. Particularly if she has or he patient has family history. Sorry, not family, travel history. Any travel history or risky habit, you can put the hepatitis as Dr. Omar mentioned. The differential again, Dr. Ala, PSC, primary sclerosing, primary biliary, autoimmune, viral, cholangiocarcinoma, drug-induced. Don't forget the drug-induced, okay? Okay, thank you, Dr. Omar and Salma. Again, the duetto, Omar and Salma. And Dr. Mahmoud, of course, Dr. Mahjoub, everyone for the attendance. Anyone has a question before ending the session?
Thank you very much.
Okay, thank you too. Thank you.
Thank you, Dr. Bas.
Most welcome. Okay. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
ورحمة الله وبركاته.